We're coming to you live at the end of day 3 of TCT 2020, and I'm joined by a great panel today, a new member today, Mamas. Welcome, Mamas.
Yeah, hey. Good to see you.
Great to have you on here, giving us the European perspective. Of course, Roxana Mehran and Ajay Kirtane, welcome you too, welcome back. Big day today for FFR. FFR before the case on CT, FFR at the end of the case, FFR. You know, what did we learn from, the forecast study? Who wants to talk about that? Ajay, do you want to take a crack at it?
Sure. I think there's been a lot of interest in FFRCT, and this was a randomized trial done in the UK that looked at an upfront strategy of FFRCT versus a more conventional strategy to sort of risk stratify patients. But recall that conventional strategy was under flux in the UK, and 60% of patients still got a CT. Essentially, the trial was a negative trial in trying to determine whether you could save money with a strategy of FFRCT. And I think Roxana pointed this out as well, is that that's because FFRCT is not cheap. And so the question really is what role does it play? I still think clinically it's useful in cases where you have these indeterminate CTs that patients and referring physicians are often really worried about, and you don't want to go to the cath lab in cases that don't need to go. And so sometimes the FFRCT can be helpful in that regard. And that is what the investigators showed. They showed there was less caths done. But interestingly, the absolute reduction in number of caths was not that great. It went from 25% to 20%. So it's not like this dramatic reduction in caths that some people, would be touting. So overall, I think it's a valuable test, but what the actual role of this test versus others is remains to be seen at present.
Ajay, I was going to say, you maybe even Mike and Mamas, Ajay, any of you. I wanted to ask that, and I asked that, I was hoping Greg would ask the investigators, and I forgot to do it in the press conference. But given what we know now using this data, I think we can figure out a price for FFRCT that could fit in a cost-effective fashion in a backward sort of calculation, right? I mean, you have all of the data from this trial. It's a large trial, 1,400 patients. You should be able to back calculate, and if you want it to be cost effective in this setting for chest pain evaluation, it should be how much? Maybe not 1,200 pounds, but
500 to cost of 5% of the caths, whatever that would cost.
Whatever it is. I mean, I think that should be able to be calculated. Do you think this is what they'll do, Ajay?
Well, it's tough to say. And also remember, though, if you look at the non-invasive arm that didn't include CT, the predominant testing modality actually was stress echo, which is different than what happens in the United States. So the cost may be different. But yeah, I agree with you, Roxana. You and I, we come from cultures that like to haggle. So let's get it done.
The thing I learned about cost effectiveness studies is it has to be able to be done on the back of an envelope for me to understand it. So it's pretty simple. Mamas, what do you think? I mean, how does this play in the UK?
Well, I mean, I was one of the investigators of this study, and for me, it's important. I mean, reducing cath by 20% is not a small thing. It's something that patients will appreciate, and particularly during the time of COVID, we don't want to be bringing patients into the cath lab and doing invasive procedures on them. Let's not forget, though, I'm not sure that this study may be that applicable to the US, because I think the results would have been very different had cardiac CT not have been done in 60% of cases. And I know that in the US, cardiac CT hasn't really gained the foothold that it has in the UK.
Mamas, is that a NIRS infrared spectroscopy in the background of you? I mean, are you looking at lipid behind you, or what?
Well, it's apparently a burning landscape.
Oh, okay.
Yeah,
all right. Well, that's great. Let's move on to target FFR. I thought that was fascinating. At the end of the cases, I guess I was dumbfounded to learn that, a fair chunk of the time when you think you're done, you're not done. You still have an FFR, a gradient, either across the stent or somewhere proximal, perhaps somewhere distal. And the target FFR group really characterized this quite nicely. We do know that those folks who have a residual gradient tend to go on and have some outcomes. They tend to be revascularization outcomes, not MI outcomes, durable symptoms. Anyone want to take a crack at this one? What did you guys think?
I mean, I thought it was a really interesting study that a third of patients reach an FFR greater than 0.9, the cutoff which below you get increased MACE events, and a third of patients end up with an FFR less than 0.8, the value at which you do the PCI. I think it's fascinating that, you know, in the patients that received the physiological measurement, 40% then went on to have a change in procedure, whether it be another stent or post-dilation. It improved the indices, you know, you got a big improvement in the indices, but didn't really impact on clinical events, although it was a small trial, and prolonged the procedure quite significantly.
You know, Mama, as you mentioned, a cut point, you know, it's kind of a continuous variable though, right? I mean, it's hard to, you know, 0.8 is a pretty good cut point, but 0.9, it's a 0.9, 0.92, we don't really know. I also asked Damien, the principal investigator, I said, you know, when you embolize, you're doing a couple of things. One, and Ajay, I've always taught you this for many years, you get a hyperemic response from embolization. And, you know, you may be screwing up a lot of your measurements, but he reassured me saying they did IMR to really make sure they hadn't screwed up the downstream microvasculature, and that this was really a valid measurement in the epicardial artery alone. So what are some of your thoughts, Roxana? What do you think?
Actually, you know, was also shocked that so few patients actually met the criteria of FFR greater than 0.9, but no matter what they did, they weren't able to actually get it to the level of, you know, so
No,
I'm
that's
not
what
so
I said.
sure. I'm not so sure if we know that post PCI, those FFR measures of 0.9 or 0.8, because we just presented data from science, you know, science data with such a low event rate. We're seeing such low event rates, and believe me, they're not doing FFR at the end of every one of those procedures. And so if that's the case, then we should have had a lot more events in the current, you know, so I don't think that that FFR of 0.8 actually holds true for clinical events post-procedure as it does pre-procedure of whether you should go ahead to do something or not. And I think you can do harm if you just keep going. And I think that was the other sort of thing that we were discussing yesterday. I don't know what Ajay thinks, but that was my take.
Well,
Yeah.
Ajay knows me pretty well. I'm definitely a, you know, not a bigger is better guy. I right size it. I pointed out to him, you know, the hazards of oversizing. I said, how much were you guys going up? He said, 0.5 millimeter. So Ajay, is it, you know, you've got well-opposed stent. I said, what if you're well-opposed on the OCT? Do you still keep going up? He said, yeah, you need to go up because the rest of the artery may be bigger than that section of the artery. Even though you're matched, you may have matched a part of the artery that's too small. So Ajay, should we keep going up 0.5
No,
millimeter?
I think, you know, that's why I think image guidance can help, because it can determine what the size of the vessel is. And I think
The reference segment.
yeah, and I think most of us on the call would do that. I think the one thing, I'll just take a big step back. There's two ways of looking at this study. One way of looking at this study is that we have no idea what we're doing in the cath lab, because clearly we're leaving FFRs that are abnormal behind. We're doing things and we're not responding to the data appropriately. I don't think that's right. I think that that's true for some people, but certainly not the majority of interventionalists. So if we take a step back and just try to figure out why is the patient there, and use the physiology to try to determine what's the best way to treat that patient. And if it's diffuse step up through their LAD, well, maybe it's a bypass surgery and not PCI. Don't just lay stent at the one place you think it's the tightest. So I think a lot more understanding needed. This is a single center study, but it certainly spurs more investigation, like defined GPS, which will be starting soon.
Yeah, you know, I think I did talk to Damien about this. A lot of the problems were in the LAD, not in the rights and the circs. So, you know, the three arteries are different animals. You know, the LAD is quite different in terms of what it's dumping into, the dynamics, the size, everything. I guess I take a little more of a less sanguine view. I kind of still think coronary blood flow is a mystery wrapped in a riddle that is an enigma that is topped in secret sauce. I've studied it for 30 years and I still don't understand it. The artery is smarter than us. I think we learned that. Now, then we have our third FFR study, defined flow. Ajay, what did you think about that?
It's interesting. It's really not a randomized design. It's more of a natural history study. And basically what it shows you is if you have an abnormal FFR and your CFR is preserved, those patients don't do necessarily as well as it was hypothesized that they would do. But I would point out that the majority of events in this trial were not hard endpoint events like deaths or myocardial infarctions.
Right.
They were repeat revascularizations, and
Right.
presumably the investigators and the patients were not blinded to their results. So I don't really know what to take of it. I do think that there's a fair amount of controversy here as well. We do have to think about the microvasculature, but how we action those numbers to our practice, I think, remains undetermined.
I think CFR, to be honest, I've become a skeptic of CFR over the years, because what we showed in one study is this CFR in the distal part of the vessel could be very different than the CFR in the proximal part of the vessel, depending upon the endogenous adenosine release. So I just find it really hard to interpret some of this. Mamas, what did you think?
It's an interesting study. I personally don't do a lot of CFR for the very reason that the study's there. When you get sort of a positive FFR but a negative CFR, then what do you do? So, you know, in my opinion, and the other problem is that there's different cutoffs for CFR. So different people use different cutoffs, and in the literature, different cutoffs are shown to have different prognostic values. So I think it's an interesting natural history study. Will it change my practice? Probably not.
Yeah. Mamas, we also saw some TAVR results today, the solved TAVI. What were your thoughts on that?
I mean, this was a really interesting study. So it was a 2x2 factorial design. It was a randomized trial of Evolut R versus Sapien 3, so balloon expandable versus the self-expanding stent, and then GA versus local anesthetic. So very interesting results. Basically that the Evolut R had lower stroke rates and much higher in the Sapien 3, and also greater AVA at the end of the procedure, but no difference in the primary outcome. And then absolutely no difference between the GA and the LA. And that's really going to, you know, question as to how we do these sorts of procedures. I mean, there is a lot of movement, certainly in Europe, where the majority are done under local anesthetic. You know, is there a role for general GA? You know, I don't know, maybe in a few patients, but not as the primary approach.
Yeah. Roxana, that stroke difference was pretty big. Do you believe it? I mean, was that believable to see that magnitude of a difference?
To be really honest, this is the highest stroke rate I've seen with the Sapien 3, and it's almost not believable. And to me, it must be a play of chance. I mean, obviously, it's something that struck everyone to look at it, and I would just be cautious in evaluating those results, given that it's a really big outlier from any other study in the past that has been done in much larger numbers of patients, with even higher risk patients who had did never reach that kind of a stroke rate.
So look at the totality of the data. Ajay, what did you think?
Yeah, and I would agree with those statements. But I do think stroke is a real issue, and that kind of has a nice segue to Dave Cohen's analysis from TVT, where it looked at sentinel use in the US and showed a range of differences in practice, and in instrumental variable analyses didn't really see a difference in stroke outcomes. The one thing about TVT, which is a challenge, and you know, full disclosure, I'm the chair of the RMP committee, but I will still say that the stroke ascertainment in TVT is different than that of, you know, the monitored clinical trials. And so I think the jury's still out, and that's why there's a large randomized trial ongoing right now with that device that a lot of people are going to wait for to be able to determine what they ought to do or ought not to do.
Any thoughts from you, Roxana?
The instrumental variables were null, absolutely, and there was no question about that. And Dave and I had a little bit of a sort of a go at it, because he was like, well, that corrects for everything, and I just can't imagine that, you know, then why would we ever do a randomized trial? But when they did use propensity score as a secondary endpoint, that did seem to be in favor of protection. But I think what it does do, as Ajay has said, is it really sets the equipoise forward. And to me, the striking finding of the study in the STS registry is how little use of embolic protection devices there are, and the variability. There are many centers, a majority of the centers have never even used embolic protection with the use of TAVR. And then there are certain ones that use 90 to 100%. So the variability is massive. And all of that brings in important limitations to a single arm, to a registry data to take a look at this. So it really does set the stage, I think, for the 2,500 patient study with sentinel versus control. And I think many will be ready to randomize against, with or without. And I think it's great.
I mean, I think the falsification endpoint that was used, to me makes the analysis more robust. I mean, there was absolutely no difference in the falsification endpoint either.
Yes.
So when you've got these sorts of numbers, 120, 130,000 patients included in such an analysis, I think we're pretty close to the true effect size. But let's see.
Yeah. Well, I've gotten a lot of direct messages and a lot of emails saying what a great meeting this virtual meeting has been, Ajay. I mean, really compliments to you and Marty and Juan and the entire TCT team and Roxana. Roxana, have you heard good things? Yeah,
no, I wanted to read an email, and this is not really about anything. It was just so lovely and kind. And it said, it goes like this, and I'll read it to you. That after 2 fascinating days, I could not contain my feelings, and I have to send you a little message just to say that you made a history and putting such an incredible and valuable program in place. I simply can't stop watching. Each session is wonderfully shaped, interactive, incredibly interesting, and I almost feel sorry when they're all finished. I want to thank you for educating the colleagues around the world and ultimately improving patient care. And I think that's when it really hit a nerve for me, improving patient care by educating our peers. And I think that's really the exact reason why we're out there, and we're hoping that many more will tune in. And I do believe that all of the societies and everyone who's continuing during these times to educate our peers, to make sure that we give evidence-based medicine and practicing that going forward will ultimately result in better patient outcomes. And that's really the ultimate goal, isn't it?
One of the nicest emails that Greg Stone has ever sent you, Roxana.
It's from a friend from across the pond, and it's not from Greg. And
Okay.
Although it does say really nice things, and it wasn't meant for that, but to basically say that for every educator out there, whether it's educating our kids, right, through Zoom, what we're doing, all of us, and all of the colleagues who've come together, the entire faculty, sharing cases, sharing our experiences, and having conversation and dialogue. At the end of the day, it's for one reason, and that is to improve cardiovascular care. And I think that's the ultimate mission for any of us in this field. And I think it's great that we could do it through education.
Well, it's something, the C now stands for couch, the couch therapeutics. You get to enjoy the whole meeting from your couch. It's actually kind of nice. Ajay, what do we have planned for tomorrow?
More trials. What's nice on the weekend is I think people will have more time. The one thing too that really hits home for me is that it's all on demand. So I think for folks later to go back and look at the sessions they wanted to, there's going to be the ability to do that. But it'll be a weekend. There's still another late-breaking trial session, late-breaking clinical science. And then Sunday, if you're a fellow, make sure you pay attention to the fellow session. Is also a big endovascular day on Sunday as well. So I certainly look forward to sitting on the couch and looking at some TCT. It's fun to see everybody's faces. We miss everybody, but at least nice to see people's faces. And we know we'll see everybody soon again.
Ajay, you did something special for the fellows. You want to tell everybody? You did something special.
Yeah, we'll do it tomorrow, I think. We've spent a fair amount of time today, but basically it's like a flipped classroom format where we'll go through cases, and it should be pretty instructive. We're looking forward to it.
And of course, we'll all be back together tomorrow, doing a wrap up for, I guess, the final day tomorrow. So thanks all of you for joining us, and thanks to all of you out in the audience for joining us here for the wrap up from day 3 from TCT, coming to you virtually in 2020.